Thank you, ma'am, for introduction. Before I start, I'm a bit anxious also because here my teacher is sitting, teacher of my teacher is sitting, and my DM examiner, Dr. Mahapatra, is also here. So I know if I make any mistake, I am going to have it on dinner. So with this, I start my talk. So we'll be discussing about problem statement. We'll have a case-based approach to microcytic anemia, distinguish need for oral and IV iron. I'll make you more comfortable and more familiar with available IV preparations and identify how chronic inflammatory conditions can impact interpretation of iron studies. So if we look at definitions, we have two types of iron deficiencies. Absolute iron deficiencies, so wherein the stores are nil, bone marrow does not have any iron. And then we have functional iron deficiency, wherein the stores are normal or reticuloendothelial system has got it, but it is insufficiently available to erythroid precursors to produce hemoglobin. And this is particularly seen in anemia of inflammation and treatment with erythropoietic stimulating agents. So if you look at the problem is huge, and particularly if we see the pregnant data, around 52% patients, pregnant females in our country are anemic. At the same time, I would like to highlight 30%, which is number in males. Unfortunately, guidelines have been a bit unfair, policies have been a bit unfair towards anemia in males. So if we come to Nasik, around 17% males are anemic. So basically, the problem is huge. Now, when we come to diagnosis of iron deficiency anemia, the symptoms are fatigue, and often fatigue is independent of hemoglobin. Many times we have only iron deficiency but normal hemoglobin, and patients are saying that they are feeling fatigued. Again, pica for ice or ice products or cold stuff is also one very specific symptom. Restless leg syndrome, brittle nails, spoon-shaped nails, headache, exercise intolerance, exertional dyspnea, and weakness are some of the clinical features. Now, how do we approach patients with microcytic anemia? Suppose we have a 17-year-old female who has heavy menstrual bleed, who had received multiple courses of hormonal pills but failed to correct her menorrhagia. Her endocrine function is normal. She presented with history of dyspnea and fatigue. Tongue is bald, angulocheilitis is there, no organomegaly, USG abdomen is normal. So how are we going to approach this case? So first set of investigation which we will order is complete blood count along with peripheral smear examination. And this is how the CBC of this patient looked. HB was 5.9, RBC count was 2.9 million, MCV 65, MCH 24, RDW was increased, platelet counts were increased, and WBC count was normal. So what did you look in peripheral smear? There was a microcytosis and hypochromia. Pencil cells were present. If the pathologist is writing that pencil cells are present in peripheral smear, yes, it is almost always diagnostic for iron deficiency anemia. And if there is thrombocytosis, in most of the cases, particularly in this clinical scenario, it's reactive thrombocytosis. Teardrop cells, if they are present, they are common for iron deficiency anemia and thalassemia, and target cells favor hemoglobinopathy. The second set of investigations. So from peripheral smear, we got a fair idea that there was possibly iron deficiency. And the second set of investigation which we will order is ferritin, abnormal hemoglobin analysis by HPLC. Because this is premarital female, if you see the CBC, RBC count was normal for degree of anemia. There were 2.9 million RBCs for HB of 5.6. So that's why we ordered it, because this was a premarital female and RBC count was normal for degree of anemia. So now what happens most of the times when I see these patients, somebody else has already seen them before they come to us. And what I see is people order iron studies, but iron studies do not include ferritin. So if at all, if anything has to be ordered for iron deficiency anemia, the first investigation should be ferritin and not the iron studies including serum iron and TIBC. Unfortunately, the panels which we have in pathology labs or even in corporate labs does not include that. You have to order it separately. So please make sure, don't order iron studies, write serum ferritin if you strongly suspect iron deficiency anemia, provided patient is not having any comorbid condition or recent infection, because ferritin is acute phase reactant and that level might go up and we might get false positive results. And if we look at the sensitivity and specificity, WHO has recommended ferritin less than 15 as iron deficiency anemia, but for practical purposes, we take up to 30 or 40, depending upon which book you are referring, as a diagnostic feature for iron deficiency anemia. Only if ferritin is inconclusive, I order other sets of investigation like serum iron and TIBC if I still suspect that the cause of anemia is iron deficiency. And this is how we differentiate iron deficiency from anemia of inflammation. And if we see if the ferritin is less than 15 and TSAT is less than 10, then it is almost always diagnostic for iron deficiency, which is absolute iron deficiency. So in this picture, this is a very nice cartoon wherein it has been depicted iron status in inflammation. So what you can see is this is RBC where the iron is less, but stores are adequate. So this is particularly in states of inflammation. And if we see in this slide, this is absolute iron deficiency, stores are nil, and RBCs also don't have or have less iron. So this is how we distinguish. Again, coming back to our patient had history of heavy menstrual bleed, but many times we have young females coming in our OPD and they have iron deficiency anemia, and we always blame it on चांगलं खात नाही, she is not eating well. So that should not be case. We should always try to find underlying cause for iron deficiency, because I think somehow we are giving too much of importance to dietary habits in today's era for this thing and missing on other causes of iron deficiency anemia. We should take in detail menstrual history of patient. Many times when you ask, females are shy, they'll say normal ahe. But it's not normal. When you go in depth, you ask them whether you are passing clots more than 1.5 inch or whether what is your pad change frequency, and then you can identify that these patients have heavy menstrual bleed. Now, why this is important, Dr. Shehnaz ma'am is going to take a specific talk on this, and I'm not going into details of this, but only remember that von Willebrand factor deficiency is one condition which is very common. Now, if I come to this simple case of iron deficiency anemia, which would have been passed away as just by replacing oral iron, we got in this patient was additional beta thalassemia trait, because again there is a implication from pregnancy point of view. She is premarital female and heavy menstrual bleed. This can lead to PPH later on while after delivery in this patient. So these were the things we got out of this case. Now, causes which are often overlooked: excessive blood donation, some people do it on professional basis, underestimation of degree of menorrhagia, occult bleeding. Many times when I write endoscopies or colonoscopies for my male patients, I will get a call from general practitioner who is referring me or physician, amala asa vatat nahi. We don't feel that this patient might have a malignancy or ulcer. But Baba, when you feel that this patient is having malignancy, already metastasis has happened. So you have to pick up these patients earlier. You have to pick them at the very early stages, and that's why it is important to scope, particularly postmenopausal females and males. If they have iron deficiency anemia, there is no excuse if you don't write endoscopy for these patients. Exercise-induced blood loss, hemodialysis, and celiac disease are some of the other things which are overlooked. Again, in farmers, worm infestation is one thing which we need to look at, and we need to, that's not a wrong practice, I feel, if we can empirically give albendazole ivermectin to these patients. Again, one thing which is missed is many patients have only fatigue, normal hemoglobin, but ferritin is less than 40. These patients also benefit by correction of iron. So what is the best time? When should you give sample for iron testings? Overnight fasting is preferred for nutritional anemias. Please remember, food does not impact estimation of ferritin. Oral iron will not impact estimation of ferritin. Oral iron, however, will impact serum iron and TSAT estimation. So if the patient is coming, now this is one more reason that I don't do serum iron and TIBC at first visit of my patient, because most of the times these patients have received iron before they are in oral form, before they are referred to us. So that's why serum ferritin is the one which we should go ahead. Bone marrow examination. Again, many times these lab reports are normal, and there have been instances wherein iron deficiency anemia was diagnosed from bone marrow examination. And it is important to know that in a chronic disease, what will be there is iron is present in bone marrow macrophages, but absent in erythroid precursors. So this is more relevant for our pathology colleagues who are reporting bone marrows. If the patient is having chronic inflammation, iron deficiency, then iron is present in macrophages, but it's absent in erythroid precursors. Now coming to the treatment part, meeting the iron needs. Iron can be supplemented in oral form. Blood transfusion is my least preferred option, and IV iron. So if the patient is having severe life-threatening anemia, only in that case we advise blood transfusion. So only if the HB is very borderline around 4, 4.5, patient is having basal Krebs, dyspnea, in these circumstances I order blood transfusion. Otherwise, even if HB is 4.5 or 5 and if the patient is stable, if the clear-cut diagnosis is iron deficiency anemia, we should give IV iron or oral iron, whatever, but we should avoid giving blood transfusions to our patient. Now coming to treatment, oral iron is recommended for most who can tolerate it. I have specifically mentioned those who can tolerate it, because 70% of patients take oral iron pills, go home, and then come again next week, doctor, I am not feeling good. I am having constipation or I am having heartburns. So many patients complain that. The recent data about hepcidin elevation after iron therapy is prompting us to go for alternate day iron therapy. So what is the concept is that when you give iron to patient, hepcidin level will increase. Now this hepcidin will inhibit absorption of next dose of iron. So please remember, there is no case for current time to give iron 2 times a day or 3 times a day. We have to, if at all you want to do it every day, once only, and preferably you can now go on to alternate day iron therapy. How much iron to give? Anything in between 60 to 100 milligram iron has been found to be equally effective even if you do it on alternate day basis. And the advantage of this thing is that patients have less heartburn, the compliance is better, and the response in long term is better. Coming to again salts which you have to give. The MR who comes and say, doctor, my tablet is gastro-resistant, tell him, Baba, please don't come back to me again. Why? Because gastro-resistant tablets are enteric coated tablets. Now, please understand the absorption mechanism of iron. Iron is absorbed in proximal duodenum and in distal stomach. So when you give enteric coated tablet to patient, that is dissolved in jejunum. So you have already bypassed the place where the iron should have been absorbed. So whoever says I have gastro-resistant tablet for you, please tell him, please don't come back. What you have to give is film coated tablet, which is absorbed where it has to be absorbed. So I prefer simple Livogen or Orofer, and here there is no conflict of interest. Any film coated tablet you can read on your tablet, and you can prefer that tablet. All salts are equally effective. The problem is more to the iron component and not to the fumarate or gluconate or any other component which is there along with that. So this is again what I was referring to about alternate day therapy. I'm not going into data, but it was found, the study was published in Lancet, and it was found that it was equally effective. Again, iron with meals or without meals. It is important. Please do not give iron with meals. Forget treatment doses. You will not give replacement dose, which is 1 mg per kg for normal individual like you and every one of us. We will not replace that from that 100 milligram tablet, because from 100 milligram tablet you absorb only 7 or 8 milligram. So if you give it with meals, 90% reduction means you will go down by below less than 1. So this is not even replacement dose which we are giving to our patients. So please do not prescribe iron tablets with meal. I rampantly see prescriptions, patients are receiving iron for 3 months, 4 months, taking after meals. And when you ask, how are you taking it? My doctor told me, ek godi jevna nantar. Take iron tablet after food. So please don't do that. What I do is I prescribe it 1 hour before food or 2 hours after food. Why? Because not very empty stomach, because many times it's difficult to tolerate. So I tell them, have breakfast, take gap of 2 hours, take it at 11 o'clock, and again have lunch at 12:30. Again, this topic has been discussed. Antacids. Nowadays, the policy is before we prescribe any drug, we write down antacid. Pantacid is the first drug which we write. So please understand, iron is absorbed in acidic environment. So please don't prescribe antacids, particularly PPIs. They are irreversible blocker. They have 17, 18 hours blockage after you prescribe them. So how the iron is going to be absorbed? So your patient will not improve even if the patient is taking it in correct way. If you are prescribing antacids, tea, coffee, phytates, almonds, all these things are not going to help. Iron absorption might be improved if taken with orange juice. For practical, I usually do not prescribe it along with vitamin C tablet, because as it is, patient is not happy taking iron tablet, so I don't want to add on another pill. You can simply prescribe with citrus juices, lemonade or orange juice. Now duration. Treat for at least 6 months after hemoglobin has normalized in order to completely replenish the stores. Understand two things. One is, iron in hemoglobin is like our current account. And iron in form of ferritin or bone marrow stores is like our FD. Now, whenever we have good FD, we can handle stress. So that's why we want a good FD also. We want good fixed deposit also. So even if the HB is normalized, don't stop iron of your patient. After normalization of HB, you have to give it for at least 3 to 6 months so that the ferritin levels improve, and only after that stop this thing. Again, for iron deficiency, please check follow-up ferritin 3 months after treatment. And this is how we do it. Now this patient came for follow-up at 2 weeks. She is not tolerating and hence not taking tablet and cannot afford or does not want IV iron, because I had explained of the side effects of IV iron. So how did we manage this patient? Instead of once a day, we switched over to alternate day. Switching from a formulation from 100 milligram to 60 milligram. Switching from a tablet to a liquid form, because that gave me advantage of titrating. I went to syrup orofer, wherein I could come down to 30 milligram, and then again went to 60 milligram and upgraded to 100 milligram. Individual taking oral iron syrup should be told that they need to do gargles after taking iron, otherwise they'll get enamel staining and they'll come back to you again. Once a tolerated dose is found, then the you can slowly increase the dose. So after 2 weeks, patient came, HB was 6, again compliance was ensured, she was taking without meals, no side effects, tolerating oral iron at 80 mg. She had anal fissure, occasional bleeding, says finances is not an issue now. What is the plan? Now this is a very good study where it was shown that if your patient has taken iron for 2 weeks, the way it has to be taken, empty stomach and a film coated formulation, if the patient is not improving, the chances that this patient will improve are very low. So what you have to do is you can switch over your patient to parenteral iron supplement. And here I come to discuss about advantages and disadvantages of both the formulation. So oral iron is effective, but again the gastrointestinal side effects are quite a few. IV iron is effective for most patients. It gives more rapid correction, ability to administer large doses. You can save a lot of money on asking your patient to come back again to your clinic by doing it a single sitting by using FCM or iron isomaltoside. Compliance is assured. You are sure that suppose patient of 5 gram is coming to my OPD and I am not giving blood transfusion to that patient, then I prescribe oral iron. Somewhere I have a bit anxiety that if this patient does not take iron tablets correctly, he might come to me at 3.5 gram next week. So I'm very sure when I give IV iron, particularly in patients who have very low hemoglobin, that the compliance has been ensured and there are no gastrointestinal side effects. Beauty of IV iron is it goes where it has to go within 55 minutes of your administration. So if your patient is having pica for mud or pica for ice, that will improve, and many times it improves while the infusion is going on. IV iron indication, the threshold to shift to IV iron nowadays have gone low. As soon as intolerance is documented, you can go for IV iron. If inadequate response, less than 1 gram in 2 weeks, you can go for that. In whom it is known to be harmful, particularly inflammatory bowel diseases wherein oral iron has been found to alter the gut microbiota and that causes problems. So in these conditions, do not give oral iron, you can switch over to IV iron. IDA with HB less than 10 or 10.5 gram in second trimester of pregnancy. Iron deficiency in third trimester of pregnancy irrespective of hemoglobin. Even if HB is 11, patient is in third trimester of pregnancy, I know this patient is going to lose blood, might have PPH, I want to be more safe, I'll prescribe IV iron to this patient. Those who have uterine bleeding and those with rare blood group. I cannot try a patient of B negative or O negative blood group at HB of 4.5 with oral iron supplement, because if this patient comes next week and if the blood bank is not having a negative blood group, I'll end up in trouble. So in these circumstances, I would give IV iron. Again, dose calculations, usually I don't use these formulas now. What we do is, this was published in ASH 19, this is how we do. Iron deficient non-anemic, around 300 to 600 is okay. 8 to 10.9 gram HB, around 1200 to 1500 is okay, and less than 8 gram, 2000 mg of iron. Again, after giving IV iron, I check ferritin after 3 months. Now, what is the risk of severe adverse effect? Many people are afraid of giving IV iron. So there was a practice of giving Avil before IV iron, and that has been found to cause trouble to your patient. Avil causes hypotension, Avil causes dizziness, so there is no case for pre-medication to before giving IV iron. And again, the infusion reactions are in range of 5 to 10%. This is what I tell my patients. And anaphylaxis, which can be life-threatening, is 1 in 2.5 lakhs. So it's very, very rare to have anaphylaxis, and most of the times what you have is infusion reaction to the for your patients. And infusion reaction is complement mediated, so Avil is not going to help your patient. So what you require for your patient is steroid. If at all I have to give pre-medication, I do it in particularly 2-3 circumstances. That is when I have a patient of bronchial asthma, when I have any patient who has got 2-drug allergy, or any patient who has got rheumatoid arthritis or any inflammatory arthritis. In these circumstances, I do pre-medication, and that too with Solomedrol and not with Avil. Now, this patient had developed flushing, which is a minor infusion reaction. You stopped, did not do anything. This patient has improved and looks happy. So many times overreacting, like giving it Avil, adrenaline, hydrocort, all these things create problem. You just stand by your patient. If the pulse is there, don't worry. Do not be in hurry to give adrenaline for your patient. Wait and watch, and then see whether you actually have to do anything. Most of the time, the reactions are infusion reaction, shivering, chest tightness, bronchospasm, fishbone reaction, wherein you feel that your fish is stuck, thorn is stuck in your throat. All these things are infusion reaction. Your patient will improve after 20 minutes if you stop. Only if there is hypotension, severe bronchospasm, drop in saturation, drop in blood pressure, absence of pulse, these are anaphylaxis, and here you have to give adrenaline. So test dose required. Nowadays, the formulations which we have, ferric carboxymaltose, iron isomaltoside, iron sucrose, do not require test dose. Again, I have seen patients receive 1000 milligram of iron sucrose. That is wrong practice. You cannot give 1000 milligram of iron sucrose. Only iron isomaltoside and ferric carboxymaltose are the products which are approved to give this thing. Again, the companies will come and say 15 minutes mein khatam ho jata hai FCM. Please be cautious when you do it at that rapid speed. You can start very slow in first 20 minutes, and then you can try to finish off within 1 hour. Doing it fast can put you in trouble. Risk of infection. Again, I have seen in COVID times, patients have been given IV iron. Please remember, iron, nothing will happen if your patient's HB is 7 gram or 8 gram. So once patient is out of infection, because Yersinia, Klebsiella, Mucor, all these things are, they love iron. So these things might increase if you give IV iron, particularly in active infection. Again, unusual weakness after IV iron. Please be aware about hypophosphatemia. There was one patient whose HB went from 5 to 11, but she was not happy with me, and we later on documented there was hypophosphatemia, and we just asked her to increase milk product, cheese and paneer and milk, and she responded. So response to iron supplementation, last few slides, I'll finish off. If there is pica, it will respond immediately, and and patient will get instant sense of well-being after 72 to 48 hours. So in children, the dosing is 3 to 6 milligram per kg per day. And last few slides about functional iron deficiency. A 56-year-old female was referred for evaluation of anemia. There was progressive fatigue, dyspnea, exertion, mental fogginess. She had rheumatoid arthritis, was on MTX. Her CBC had a ferritin of 89 and C-reactive protein was 1.8, and there was HB of 7.9. So this is a beautiful cartoon wherein WHO cutoffs like ferritin less than 30 and TSAT less than 20 is plotted. This is what is absolute iron deficiency. But in this study, what was done, or the data was collected, wherein bone marrow iron stains were done, and at the same time, for normal bone marrow iron stains, various iron values were put in graph. Now, when you see patients who did not have stainable iron in bone marrow and they had some underlying chronic inflammation like CKD or heart failure, the ferritin level was seen up to level of 300 or 400, and TSAT levels were seen even more than 30, but still these patients did not have bone marrow stainable iron. So to summarize this, if our patient is having ferritin of 200, if there is any underlying chronic inflammation condition, TSAT is less than 20, still this patient is going to benefit from IV iron or oral iron supplement. In inflammation cases, we prefer IV iron over oral iron. So if we see this patient's serum iron was 54, we did further analysis, TIBC was 300 and TSAT came to be on lower side. So TSAT of 18 and ferritin of 89, this patient falls in range of iron deficiency. Again, even in anemia of inflammation, do not forget to look for if there is any associated bleeding which is happening from GI or genitourinary tract. So to conclude, ferritin is most important in investigation, particularly in healthy individuals, and ferritin is not most accurate investigation in non-healthy individuals. IVIN is safe than most of us think. Cutoffs are different to diagnose IDA in chronic inflammatory state and requires combination of test and clinical correlation. So thank you, and thank you everyone, and ISHBT and IMA for giving me this opportunity.